Hello, today I'm going to talk to you about regenerative medicine for musculoskeletal conditions and the implication for physical therapy practice. So let's start off with a few case studies. First, we have Jimmy, who's a 19-year-old football player with an acute grade 2 hamstring strain who wants to return to sport as soon as possible. Next, we have Timmy, who's a 50-year-old avid golfer who's been dealing with rotator cuff tendinopathy for 8 months. He went to physical therapy for 3 months and then received corticosteroid injection with minimal improvements made. Last, Kimmy, who's a 65-year-old marathon runner who has knee osteoarthritis. She was recalcitrant to physical therapy, corticosteroid injection, and viscosupplementation. She wants to avoid getting a knee replacement due to eagerness to stay active. So first, I'd like to go over a brief but necessary review of the body's natural healing response so we can all be able to understand the biological basis for what we'll be discussing today. So there's 3 overlapping phases of healing. First, there's the inflammatory phase, which occurs immediately after injury. This is associated with focal inflammation and hemostasis, which is initiated by platelets. Then the proliferation phase, which occurs a few days after injury. During this phase, there's cellular proliferation and differentiation, as well as angiogenesis and vasculogenesis. Lastly, there's the production of collagen and connective tissue. The last phase of healing is the remodeling maturation phase. This takes up to a year to be complete. During this phase, the preliminary extracellular matrix is replaced by an organized matrix of stronger collagen. So why would an injury or disorder not heal? So first, it can be because of the macro environment, so the severity of what happened. For example, a retracted rotator cuff tear or a displaced fracture. Second, it could be because of the microenvironment, such as cellular impairments from age-related changes, like reduced cell pool or cellular senescence. It could also be because of impaired differentiation of stem cells and progenitor cells. Also, it could be because of signaling impairments, such as cytokine imbalance, growth factor or hormonal decline, such as insulin growth factor, and impaired signaling, which could be because of loss of mechanosensitivity or from disuse. So the current model, let's go back to our case studies. So the patient gets hurt. As long as it's not traumatic and they need surgery right away, usually they start with conservative care. So under conservative care, we have PT and OT, viscosupplementation, NSAIDs, opiates and analgesics, and is there anything else anyone could think of? I'm glad you said it. Yes, corticosteroids. So after conservative care, you have 2 outcomes, either successful outcome and you go back to your sport or whatever you want to do, or you have an unsuccessful outcome. Then you could either have surgery or the option to wait and see, live with it. We could try to teach the patient about pain science and that their pain is just in the brain, or delay surgery. So how do we handle failure to improve? What if there was an option for patients who are recalcitrant to conservative care before having to commit to surgical intervention? What's the next step? That's where regenerative medicine comes in. Regenerative medicine is the process of harnessing the body's innate ability to heal via modulation of cellular and molecular activity. The goal of regenerative medicine is to stimulate and harness the body's own healing capacity to repair or replace tissue function loss due to age, disease, or damage. So let's dive into regenerative medicine for musculoskeletal conditions. So first we have platelet rich plasma, also known as PRP. And then we have stem cells, which can be found in bone marrow aspirate and lipoaspirate. Today, I'm going to be mainly speaking about PRP. So a little bit of nomenclature. So first, differentiation means when an unspecialized or less specialized cell forms into a specialized cell. For example, a stem cell, which is unspecialized, differentiates into a tendon progenitor cell, or TPC, and then TPC differentiates into a tenocyte, which is a mature specialized cell. And then stem cells are the body's repair system. It's an undifferentiated cell with multiple pathway capability and may differentiate into a mature cell, such as a tenocyte, chondrocyte, myocyte, or osteocyte. So a little bit about platelet rich plasma. So today I'm going to be talking about a bunch of conditions, such as tendinopathy, muscle strain, fasciopathy, disc disease and sacroiliac pathology, and osteoarthritis and ligament sprains. So what is platelet-rich plasma? Platelet-rich plasma is an autologous biologic derived from processing the person's own blood to produce superphysiologic cell concentrations that are injected into the site of injury. PRP has between 3 to 9 times more platelets than normal whole blood. The key components in PRP are concentrated platelets and mainly alpha granules. So now I'm going to dive a little bit into the biological components in platelet-rich plasma. So first, as you know, there's platelets. Platelets start the clotting cascade and creates a provisional matrix construct which serves as a scaffold for arriving cells. Platelets contain alpha granules. Alpha granules release growth factors and cytokines. Growth factors bind to cell surfaces to promote signaling that initiates cellular upregulation and expression, which is responsible for proliferation and differentiation of stem cells. Growth factors also reduce inflammation and encourage repair. Some examples of growth factors are platelet-derived growth factor, which works to establish a blood supply through neogenesis, and insulin-like growth factor, which influences cell growth, proliferation, and differentiation of cells, as well as increases collagen synthesis. Evidence suggests leukocyte-rich PRP has higher concentrations of growth factors, and they play a key role in the healing cascade. Alpha granules also release cytokines. Cytokines are signaling molecules that attract stem cells to the injured area and serve to mitigate inflammation. Stem cells provide the basis for maintenance, repair, and regeneration of tissue. Another biological component are fibroblasts. Fibroblasts are connective tissue cells that produce collagen and can differentiate into many cell types, such as a tenocyte or chondrocyte. In PRP, there's also going to be minimal stem cells, and then depending on preparation, red blood cells or white blood cells. So let's talk about the procedure a little bit. The procedure varies by facility, and currently there's no consensus on the best method to prepare PRP. So first, an antecubital blood draw will be taken. As you can see the picture on the left, the blood is going to be inserted into the centrifuge. Then if you see the picture on the right, the top layer, which is plasma, is going to be removed, as well as the middle layer, which is the buffy coat, and minimal red blood cells. And then the bottom layer, which is all red blood cells, is going to be discarded. Then it's going to be put back in the centrifuge, and you'll get the product on the picture on the right. So all the clear yellow, that's platelet poor plasma, and that's going to be discarded. And what's going to be left is the buffy coat, which is growth factors and white blood cells, as well as the dark red on the bottom, which is residual red blood cells and platelets. So picture all the way on the left, that's the final product. It's then going to be extracted to a syringe, and then in some cases put under photoactivation, which stimulates anti-inflammatory cytokines. So the typical procedure: you get the injection of PRP, post-procedural ice is needed, and a prescription for physical therapy, and follow up within 2 to 6 weeks and repeat PRP if inadequate or incomplete response. So let's dive into the evidence for PRP. So first I'm going to start off with osteoarthritis. So for knee osteoarthritis, a few studies. There was a meta-analysis of randomized controlled trials that compared PRP to hyaluronic acid. There was similar improvement at 6 months, but at 12 months, PRP was found superior to hyaluronic acid for pain and function. An additional study of systematic review and meta-analysis of randomized controlled trial found that PRP was superior to hyaluronic acid, saline, prolozone, and corticosteroid injection. This was based off of pain, stiffness, function at 3, 6, and 12 months. Moving on to hip osteoarthritis. Randomized controlled trial showed that PRP was comparable to hyaluronic acid for pain and function at 6 and 12 months. Another study showed that PRP was superior to hyaluronic acid, corticosteroid injection, and saline. Moving on to the shoulder. PRP was found to be superior to corticosteroid injection, ultrasound, and control. This was based on range of motion, pain, and function at 12 weeks. So the clinical evidence for shoulder tendon pathology. A study on supraspinatus tendinopathy, or partial tears less than 1 centimeter, showed that PRP was superior to dry needling for pain and disability at 6 weeks and 6 months. Another study showed that PRP was comparable to saline for function, pain, and quality of life at 3 weeks up to 1 year. A case series showed that at 8-week follow-up, diagnostic ultrasound showed complete healing in 11 patients and partial healing in 5 patients. 81% of completely healed rotator cuff tears were intratendinous tears. This was based on pain and function at 8 weeks and 3 months. The last study was on partial rotator cuff tear and showed that PRP was superior to corticosteroid injection for pain and function at 12 weeks, but then at 6 months, there was no statistical significance between the groups. Moving on to lateral epicondylalgia, a systematic review of randomized controlled trials showed that 73% of people in the PRP group had successful treatment compared to corticosteroid injection at a 1-year follow-up. Successful treatment was based on a greater than 25% reduction in VAS and DASH score without re-intervention after 1 year. In this study, the corticosteroid group was better initially and then declined, and the PRP group progressively improved. 3 studies compared PRP to corticosteroid injection, with 2 reporting no difference at 3 months. Moving on to Achilles tendinopathy. 1 study compared PRP and eccentrics versus saline injections and eccentrics. Both groups reduced pain, improved activity level, and decreased tendon thickness. A case series study of 15 patients showed that PRP improved tendon morphology as well as pain and function. Several studies compared PRP and eccentrics to eccentrics only and found that generally the addition of PRP does not alter outcome. Both groups improved with morphological characteristics, pain, and function. Moving on to chronic patellar tendinopathy. So a meta-analysis compared PRP to shockwave and dry needling and found that no group difference at 3 months for pain, mobility, function, and sport, but at 6 months, PRP was superior to other interventions. This next case series was really interesting. It focused on PRP versus PRP with having a previous corticosteroid or surgery. There was 36 patients and both improved in pain and function. However, the largest improvement and more likely to benefit from PRP was if they didn't have a corticosteroid injection or surgery. A randomized controlled trial based on leukocyte-rich PRP versus leukocyte-poor PRP versus saline showed that there was no group difference for pain, mobility, function, and sport for chronic patellar tendinopathy. Moving on to plantar fasciopathy. 2 meta-analysis reports compared PRP to corticosteroid injection and found that there was no difference in pain and function up to 12 weeks, but superiority of PRP with suggestion that improvements may require greater than 3 months up to 24 months. A case series of 9 patients received PRP for plantar fasciopathy, and 7 out of 9 patients reported pain-free at 1 year with reduced thickness of tissue. Moving on to acute muscle injury in athletes. Most of these studies are based on hamstring strains. A few studies have evidence on gastrocnemius and quadricep strains. So a randomized controlled trial for patients with acute grade 2 hamstring strain compared PRP versus saline. In this study, there was no difference in return to sport time or re-injury rate. The next study focused on acute grade 2 hamstring strain, gastrocnemius, and quadricep strain, and focused on PRP and rehab versus rehab alone. The study found that PRP was superior for earlier return to sport, lower pain severity scores at all time points. However, the rate of recurrence during 2 years was not statistically significant. Another randomized controlled trial comparing PRP in rehab versus rehab only showed the same thing, that PRP was superior for earlier return to sport and actually showed that return was even quicker, 26.7 days versus 42.5 days. And then lastly, a systematic review and meta-analysis for hamstring strain showed that PRP was inferior to eccentrics and placebo for return to sport. The last conditions that I'm going to speak about have very limited evidence on them. A case series of 25 patients with grade 2 UCL sprains focused on PRP with PT and a varus loading brace. Follow-up MRI showed full ligament reconstitution, decreased pain, and improved stability in 20 out of 25 patients. Moving on to meniscus tears. So 10 patients received PRP injection for their meniscus tear. 4 out of 10 decreased meniscal lesion on MRI at 6 months. 6 out of 10 patients increased their sports activity, and 4 out of 10 opted for surgery. Let's talk about acetabular labral tear of the hip. A pilot study of 8 patients showed that PRP injection into the labral tear reduced pain and improved hip functional activities as rated by the Harris Hip Score. And lastly, symptomatic chronic disc pathology. A randomized control trial compared PRP to placebo and found that PRP was superior for pain, disability, function, and patient satisfaction. Lastly, a case series showed that PRP decreased pain and disability at 1 month up to 6 months. However, there was no structural change, no adverse events, or herniation. So let's talk about adverse response. So typically, patients are going to be sore for about 3 days to 1 week. They might experience pain, redness, swelling, local heat, and stiffness. Let's talk about the recovery phases. So every physician has a different protocol. During the acute phase, pain-free movement is encouraged and avoidance of complete rest, and then ice as needed. In the late acute phase, patients should perform passive and active range of motion, submaximal isometrics if PRP was injected into a contractile tissue. If not, then you can perform full effort isometrics. Protected loading, such as low resistance weight bearing and cycling, UBE, or the Alter-G. In the subacute proliferative phase, the patient can do max isometrics, early range eccentric loading, and advanced loading such as body weight reduced squatting in the total gym or the elliptical. In the last recovery phase, the remodeling and maturation phase, the patient can do full range eccentric loading and full loading such as running. So some closing thoughts. Clinical evidence identifies PRP as a potentially beneficial intervention for tendinopathy, osteoarthritis, discogenic pain, and acute muscle injuries. A key thought is that regenerative medicine needs to have a co-introduction of mechanical forces and exercise. Isometrics and eccentric overload offer synergistic effects. Repetitive loading of joints promotes upregulation and counters effects of inactivity. So what are the pros of PRP? It's natural and has a greater safety profile than corticosteroid injection, opiates, and surgery. Goal of resolving the inflammatory response and promoting tissue regeneration. The biggest pro is that there's decreased recovery time compared to surgery. The cons to PRP is that most likely it's not covered by insurance and can be expensive, $750 and more. Also, there's inconsistent outcomes, as you saw in the research that I presented. And lastly, the tissue and microenvironment modulation takes time, so people need to be patient with their outcomes. So regenerative medicine gives your body the opportunity to start the healing process again. PRP is armed with concentrated growth factors and anti-inflammatory cytokines and exposes areas of injury or degeneration to a biologically enhanced healing environment. The growing interest of regenerative medicine resides in the need for a minimally invasive intervention with an excellent safety profile that requires minimal recovery or downtime from activity and sports. Thank you very much.